Hello, everybody. I'm Sharon Moore, and you are listening to Wow Words of Wisdom. It's a resource delivering expert opinion right to parents' fingertips on children's sleep and airway health. Why? Because every child has the right to get the sleep they need every night to be healthy and happy. Our experts are from medical, dental, and allied health disciplines. And on today's Wow Chat, it gives me great pleasure to introduce Dr. David Mc Intosh, who has a number of feathers in his cap. But let's hear a little more about him. He's an ear, nose, and throat specialist. With particular interest in airway obstruction and the relationship between ear, nose, and throat problems and facial and dental development, including middle ear disease. He has a special interest in how snoring and sleep disorder breathing impacts brain function in children. He's completed advanced surgical training in ear, nose, and throat and head and neck surgery. He's done pediatric ear, nose and throat training at Starship Children's Hospital in Auckland, New Zealand, and is passionate about Indigenous health. During his career, he's had memberships with the Australia and New Zealand Society of Pediatric Otolaryngology, the Australasian Rhinological Society, and the Australasian Sleep Association. He's also a fellow of the Royal Australasian College of Surgeons. He's a speaker. He's presented on ear, nose and throat topics throughout Australia and also overseas. He's an academic and an author, having published in peer-reviewed journals worldwide. He's the author of 3 books: Snored to Death, Are You Dying in Your Sleep? Don't Ignore the Snore, and Sleep Disorder Breathing, A Parent's Guide. He's also authored a chapter in and is editor for a forthcoming medical publication called Growing into Breathing Problems. It will be published by Springer later 2024 or early 25. And it's a compilation of multiple chapters from medical, dental, and allied health specialists on children's airway health, growth, and development. Before we go on, and in case there are patients listening, please note that the following information is provided for education and information purposes only. It doesn't substitute medical advice or professional services specific to your personal circumstances. It's information that's not for diagnosing or treating a health problem. If you need personalized medical advice, please consult with your licensed physician, dentist, or other qualified health provider specific to your circumstances. But without further ado, a very big warm welcome to Dr. David Mc Intosh. Hello, Dr. David Mc Intosh. Thank you so much for being here to share some of your pearls of wisdom, of which you have many. We're going to talk about the primary reasons a child is referred to an ear, nose and throat specialist when they have breathing dysfunction. This is your specialty, right?
It is indeed, and thank you for having me. This is a great initiative.
Well, it's an absolute pleasure. And the first question I'd really love to kick off with is something I think very special to you, and that is the research showing impact on children's brain function when they have sleep disordered breathing.
Yeah, absolutely. So when we look at the whole science of sleep, it's only something that's been on the radar within the past 100 years. And it's probably come to the fore because of this thing called electricity, which has mucked up a lot of our, behaviors and lifestyles. And the other thing that's done it is the way that we sleep. So we've gone from all sort of crowded into one small space where the parents and the kids were all bundled together, to where we have houses that are spread out, where the parents can put their child to sleep and then disappear and so forth, and then not have to worry about them until the morning. So we really have this gap in this time of the parents being aware of what their kids doing, and also, parents just not being aware that we have these things called breathing dysregulations. And from that point of view, then not realizing, the crucial element of good breathing and coupled with good sleep on how the brain works. And when we look at the brain, it's not, an insignificant part of our makeup. It's the thing that allows you and I to be doing what we're doing right now, having this conversation and using our knowledge and so forth. And in children, and this obviously sometimes disappoints adults, but children, their brain are far more active than adults are. And that's because children are on a learning curve. There's a whole lot of processes that go on from infancy, from that first breath to then coordinating breathing and feeding to then crawling and walking and talking and so forth. And this assimilation of things then leads on to school. So reading, writing, and arithmetic, the three R's. But also, learning to play sport or play the piano. And, if they've got more than one language they've got to pick up. There's a whole range of things that happens as children grow and develop. And all that learning and so forth is founded at the time when they sleep. That's actually when we learn. So we are given information and experiences during the day, but it's when we sleep that the brain processes that information. And to do that, the brain needs to have a really good, clear run at it. And if you're not breathing properly, that interrupts the process.
It sure does. And there was a time in history when doctors thought that the brain went to sleep during sleep, right? It switched off, but it's quite the opposite. In fact, it burns more oxygen and more energy through the night. And so, this breathing that can interrupt sleep, how would you define that breathing dysfunction?
So there's different pathways that lead to the same outcome. So the outcome is that the sleep patterns, which we can measure and monitor both from a clinical and from a research point of view, are very well understood and basically mapped out through the night as a sort of a plan of attack. And having a breathing problem can interrupt it essentially in two ways. One way is that the breathing problem, sort of some form of obstruction, leads to the oxygen level dropping. And if the brain is desperate for oxygen, it's quite greedy actually when it comes to oxygen and blood flow, because even though it's about 9% of the body, it takes 20% of the blood flow. So it's a very, very metabolically, as you've said, active system. And if you have an inadequate amount of oxygen, then you have a system problem. So that's one way. The second way, though, is that you can have moments of what's called arousals. And that's where the brain is stimulated back into action and it's taken off course from its plan of the day. And that can happen because, again, the oxygen drops, but also just by virtue of just having a little choking episode. So much the same way, if someone was to come up from behind you and start choking you all of a sudden, you'd be startled into action and totally diverted away from whatever it was you were doing at the time. It's no different when we sleep. And those disruptions interfere with the sleep patterns and cycles, put things off course, and then the brain has to hit the reset button and it starts all over again, or tries to pick up where it left off but doesn't quite do quite the same job. And if we have repeated episodes of that through the night, well, that's just an absolute disaster. And that's the problem with the kids, is that they actually don't need that many of these episodes to disrupt the quality of their sleep.
And it could be described as airflow limitation. Somewhere in the airway, there's a restriction that interrupts breathing, that then interrupts sleep. And what would be some of the most common causes of that?
Yeah, so the beauty of this is that we can just break it down anatomically. If we look at, where is the air trying to get from A to B? Well, it's got to go either through the nose or as a backup option through the mouth, and then down through the throat, through the voice box, down the windpipe and into the lungs. And in the mainstay, the majority of problems are centered on two places, the back of the nose and the back of the throat. And that correlates with the adenoids, which sit at the back of the nose, and the tonsils, which sit at the back of the throat. So either one or the other of both of those actually account for, in the ballpark, about 80% of all of the things that we would sort of lump together in terms of causing an airflow limitation. Now, it's not to say that obviously, 80% is not everything, but, that is the big player in the game. So people can lose sight of that when they talk about the other causes and contributing factors. Still need to go back to basics, that they are still the number one player in the game. But there's other things that are coming along. And one thing that I've certainly noticed over time is the increase in the contribution to problems caused by nasal allergies. This is a hay fever type thing. It could be grass, dust, animal, mold. It's usually something airborne rather than food related. And in
Mm.
context, it causes swelling of the skin lining of the nose. The nasal passages then start to get blocked over. Those blockages then lead to trouble breathing through the nose, a transition to mouth breathing, and the knock-on effect that's associated with that. So that would be by far the number two player in the game. And then the next thing that we would probably come across would be related to the jaw and the teeth development. And this is where things get tricky, because it's not to say that it's one or the other. It's often mixed together. So when we look at kids with airway problems, around about 40 to 60% of those have jaw orthodontic problems, which they also contribute to airway problems. And if we look at kids with jaw and orthodontic problems, well, again, about 2/3 of those have airway problems. So we're looking at the same child with similar problems, different perspectives. And we need to keep a global viewpoint to it all, because it's very easy for me to blame everything just on ENT. And it'd be very easy for everyone to blame it just on jaw. But we've actually got to work together and look at the whole picture. And the way that the jaw comes into play is very simple. The top jaw is one of the founding structures that the nose sits upon. So if the jaw is narrow, the nose is narrow. So that's an easy way of explaining that. And then downstairs, the space through the mouth. Again, if the jaws are sitting in narrow, well, then the space through the throat is narrow. The other problem is that jaws don't just sit narrow from side to side, but they tend to sit back as well. So that squashes things back, and that again limits the space. And that makes the more likely that the ENT problems are then going to be an issue, because we don't have as much space to play with. So this is all sort of tangled together in a intricate web.
And
So they would certainly be the big three: tonsils and adenoids, the nasal allergies, and then the jaw. And then we have the other things. Sometimes the middle partition of the nose, the nasal septum, can be crooked. We can have tongue problems. We can have rare things like cysts in the throat. There's tonsils that sit at the back of the tongue. There's not to say that there's not rare stuff amongst it all, but I always like to keep the big picture in mind, because otherwise you can get lost in the weeds and then not see the forest.
I love that explanation, and I really like the way you're describing the morphology of two different kind of things. The hard skeletal morphology, the shape, size, and position of the jaws, which will affect what we say, whether the airway is the size and shape of the airway. But you're also talking about soft tissues inside, and there's lots of different soft tissues. Like you were talking about the skin tissue that lines those hills and valleys in the nose, and then you were talking about the tonsils and adenoids, and also the lingual tonsils. That's a lymphatic tissue, and when they swell or get congested, they take up space in the airway as well. Yeah. So an allergy you mentioned is pivotal, it's critical, and lots of kids get allergies. So, you know, from what you're describing to me, there are non-surgical treatments that you might recommend. What would you recommend?
Well, this is important. I mean, when we look at any medical condition, we take a history, we do an examination, there may be some pertinent investigations, but when we come to treatment, I think the thing that's really important for this airway limitation is targeting the treatment to the problem. So, for example, if the problem is nasal allergy swelling, well, taking out tonsils and adenoids is not going to fix the problem, because that's not the cause of the problem. The presentation might be the same. You could have two kids. We can bring two kids in. One's got tonsil and adenoid problems. One's got nasal allergy problems. And on paper, they look and sound the same until we look at them, and then we go, oh, well, this kid's got allergy problems and this kid's got tonsil and adenoid problems. Well, they might, have the similar history, very different clinical findings, very different causes, and very different treatments. So it's important to tailor things to the cause. So people get a bit tripped over. You say, oh, well, you're going to go and see the surgeon. Oh, so you're going to have surgery. Well, no. You're going to have an assessment. And as part of that assessment, for example, if it's nasal allergies, well, of course, we're going to start managing those with medications. And so there is a role for surgery in certain contexts, but the mainstay, it's medications. The flip side, if it's big tonsils and adenoids, we don't really have anything that's effective medication wise. You can try some lifestyle factors. It's a bit hit and miss. Sometimes you get lucky, sometimes you don't. But in the mainstay, big tonsils and adenoids is a surgery thing. So you can basically mix and match what needs to be done depending on what's going on. And then it's important to bring in other factors in play as well. So if the jaws are a problem, and that's the only problem, well, it's not ENT surgery and it's not even medication. It's off to the dentist and the orthodontist. And then, as you well know, and as I think we're coming to appreciate, there's a whole lot of other muscular functional dysfunctions that could get tied up in this. And unless we're addressing those as part of the rehabilitation, we can make everything look good on paper, but it still doesn't work properly. Because the kids have developed certain patterns and so forth in their motor planning and function, which then needs to be addressed so that they can make the most of the airway that everyone's trying to give them.
Yeah, and you're making such a great point there. There's a very well-known paper by Dr. Christian Guilleminault that talks about relapse after tonsil adenoidectomy of sleep that's disturbed by breathing, when myofunctional therapy or muscle toning activities haven't been followed through. So there is an important role for that. Allergy you talking about is a really big factor. What are the pathways do you recommend for your patients with allergy?
Yeah, so look, nasal allergies, the underlying problem is let's just keep things simple because, like I said, otherwise it gets complicated. Let's just work on the premise that's the child's only problem from a medical point of view and from an airway point of view. Their problem is they've got all the hallmarks of some form of nasal allergy, presenting with breathing problems because the skin lining is swelling over and occluding the nasal passages. The kids snoring to some degree, mouth breathing at times, getting poor quality sleep, struggling through the day. So that's sort of, let's use that as the canvas to paint on. So they come and see someone like me and we go, right, well, this looks like nasal allergies. So here's what we're going to do. We're going to start some medication, which in the mainstay first line treatment is a nasal spray. Now, the nasal spray is a steroid-based medication. It's an anti-inflammatory steroid. So it's to calm down the irritation of allergies. It is not a cure. It is simply a band-aid to buy some time to start looking at what else we need to do. So we start on, look, this kid's in trouble. Let's start helping them. But that's just the beginning. The other prong of attack is to look at the cause. And in that context, in this day and age, we have two ways that we can check for allergies that affect the nose. One is through a blood test, and the other is through what's called skin prick testing. The blood test is to look to see by taking a sample of blood if there's reactive antibodies to certain things, and the things we look at are grass, dust, animal, and mold. And the other thing that I do as part of that is I also get their iron checked. One, we're already there doing a blood test, but the reason for that is that nasal allergies are an inflammatory disease. There's an overflow effect within the body causing inflammation that and people are quite surprised, but about a third of people with nasal allergies, it impacts on gut function, specifically iron absorption. So around a third of kids or adults for that matter having hay fever allergy problems can also have low iron in the background. And low iron adds to breathing problems, energy problems, and sleep problems.
It
Furthermore,
sure does, yeah.
yeah,
Yeah.
yeah, and then furthermore, low iron makes allergies worse. So you've got a vicious circle there. So that's my start point. And then if we've got an iron problem, well, we start addressing that either through diet or supplement, depending on their levels. And then if we have identified allergies, I get them off to see an allergy doctor as a baseline assessment, where they will then do the skin prick testing, just to sort of make sure that the blood test and the skin prick testing correlate, with a view then to a conversation of what's called immunotherapy, which is a desensitization program to try and help them get used to the environmental problems. You can't avoid grass, you can't avoid pollen, you can't avoid dust mite, you can't avoid mold. Animals, to some degree, you can mitigate against, but most people don't want to. So you sort of work around those things, and then so that's that part of the journey. And then they circle back to me after about 3 or 4 months. By then, we've had a trial of this medication. We've got some understanding on the triggers. We've got an understanding on their iron. We've got some feedback from the allergy doctor. Uh, and they may have even potentially already then decided to start some desensitization therapies. And then when I see them in a few months, the crucial thing for me when I look at allergies, there's two bits. There's the breathing and there's the everything else. My job's the breathing bit. So when they circle back, if the nose is still blocked, the medication is not delivering some benefit with regards to breathing, then we bring in a surgery option, which is to surgically trim down the swelling, just to reset it back to normal. Just get that nose hit the reset button and make them less dependent on medications. But also then it facilitates the medications getting in and working better because we've unblocked them some more. And then moving forwards, again, using the allergy desensitization treatments, working towards a situation where the child is in, breathing and sleeping well, and also as an added product, not afflicted by the discomfort and so forth of having nasal allergies, because they are quite disruptive and uncomfortable. And can be a little bit socially an issue. And also, as an extra side benefit, reduces the chances of their disease progressing into asthma. So there's a lot to be said for picking up these nasal allergies, and one thing that I get frustrated by is they say the feedback is say, oh, it's just allergies. Well, that's nonsense. That's like saying it's just cancer, or that, oh, it's just mild allergies, and it's like, well, it's just mild cancer. And they're allergic to the common stuff. Oh, they got the most common cancer. I just don't buy into the belittling of allergies, because we know so much more now in terms of how detrimental they are to the whole body system as a whole, that we really want to take them seriously and get things remedied sooner rather than later, so that we can put these kids onto a much better life trajectory.
Yeah, and allergies are so common these days, more common than they used to be. How do you monitor the nighttime breathing? What are the tools that you use to monitor changes in nighttime breathing?
Yep. So I use the parents, because when you look at the science and research, that's the most reliable thing if you can get the parents to do it. And that can be a challenge sometimes. There's a level of engagement that come with that, but let's just work on the good side of the fence. I ask the parents, go in there, have a little snore score and go, all right, mouth open, mouth closed, snoring, not snoring, lying comfortably or tossing and turning, restless, sweating at night, teeth grinding, sleepwalking, sleep talking, night terrors, anything that suggests that the sleep patterns are being interrupted for whatever reason, breathing being one of the most common, but not the only. And then getting a viewpoint from the parents. Is your child waking up, good to go, or are they slow to go and tired in the morning? Because, if they're not waking up refreshed, well, there's a problem there. So it gives us that sort of, clues and guidance. All of the monitoring devices that you want to nominate are fundamentally flawed. They don't give us the clinical accuracy that we would rely upon. Not to, it's that, people might want to use them as a substitute, but just being mindful of their limitations. And in complex cases where things are not making sense, then we can sort of go to sleep labs and do sleep monitoring and so forth, just to try and get a better understanding to the situation. Are we dealing with a sleep problem that is related to airway problems, or are we dealing with a sleep problem that's completely separate to that again? But in the mainstay, a lot of it, when you even look at the science, comes down to parental reporting being so reliable, when the parents know what to look out for. And I think that's an important step of the education curve that we need to walk through.
Yeah.
Again, is it's something that someone had told me it should just be in the baby book. Every parent, when they get that instruction book, it
Absolutely.
should be there as a
Yeah.
thing.
Yeah. A lot of the questions that I have had clinically over the years is, well, I don't actually know what I'm looking for or what I'm listening for. And
Correct.
so those conversations that seem quite simple if you understand the area are not that simple to parents, and so we really need to spend the time educating them and helping them understand, you know, what are we looking for, what is ideal or good breathing during sleep, and what is breathing that we don't want to see during sleep. And it's not just about the vibrational noises of snoring, is it? I mean, any noisy breathing is an indicator that there's some kind of resistance for breathing in the airway, somewhere in the pipeline, so to speak.
Yeah.
So, are there, you know, let's jump across to surgery, because sometimes you have to do surgery.
Yeah, of course.
And does a child's age impact your decisions about doing surgery or not?
Not the slightest. So, you know, parents will be in the mindset of to say, "Oh, look, they're too young to have surgery." What that needs to be reprogrammed into is they're too young to have a problem. And what we know from the science is that the younger the problem starts from an airway point of view, the worse their long-term outcomes. And the longer that you leave it untreated, the worse their long-term outcomes. So children are very, very fragile in some respects and extraordinarily resilient in others. But when it comes to brain development and function, they're extraordinarily fragile. And fortunately also very plastic in terms of being able to play catch up. So to give them the best chances, you find a problem, you fix it, and the best time is where you find it there and then. So sometimes, you know, from a logistics point of view, in terms of accessing hospitals and their licensing and infrastructure, there might be some age limitations upon hospitals. So, for example, some hospitals don't treat children. You know, they're only allowed to see people that are over the age of 16, for example, whereas other hospitals might have an age of 4 or 2 or 1 or 6 months. You know, so every hospital has its own race to run there. But you know, the youngest that I've done adenoid surgery on was a 6-month-old. The youngest I've done tonsil surgery on was 11-month-old. The youngest kid I've heard of having tonsil and adenoid surgery was 6 weeks old.
Oh,
So,
okay.
you know, there's no rules. You know, there might be in reflecting on parental expectations, understandings, and assumptions. But again, not a criticism because they don't know what they don't know. Um, but you know, there's a lot of misunderstanding about, you know, the age of the child and the timing of the problem and then the timing of the solution. And you know, the best time to find a problem is early, and the best time to fix it is early. You know, we don't have these conversations about, you know, kids with cancer. It's like, well, how young are they before we can give them chemotherapy? It's not even a conversation. It's like, oh my gosh, we've got to treat them.
And
So,
I,
so then
yeah.
we need to have that similar mindset when it comes to airways. Like, oh my gosh, we've got to fix this.
Yeah, and I guess for parents, they, with the word surgery, especially with young children, can be quite a frightening word for them, and they're worried about risk.
Of
So
course.
I get that would be a deterrent for a lot of parents.
Yeah.
Yeah, and I'm really interested because you raised that that question around, do kids, how plastic are kids' brains? You know, we know that 90% of brain development is complete by the age of 5, so it really truly is a period of prolific growth and development of the brain. And the research is a little vexed in terms of sleep disorder breathing, and will they grow out of it or won't they grow out of it? And there I'm thinking about Professor Karen Bonnock's research that shows untreated sleep disorder breathing before the age of 5 results in behavioural problems in school after the age of 7. And so there's a bit like some indicators there of that ripple effect. And there's other research as well that indicates sometimes they might not grow out of it. So I think that that's a question that's still sitting there largely unanswered. I don't know what your thoughts are on that.
Well, that paper of Karen Bonnock that you've referenced that was published in 2012 is really is the paper. You know, that they looked at 12,000 or thereabouts children over the course of the first 7 years of their life, identified those with sleep disordered breathing, which is the permutations of airway obstruction, whether it's mouth breathing or snoring or where they stop breathing with sleep apnea. But there was no intervention. That was the thing, and they then looked and said, what does happen to these children? And this is where you've got to be careful about what we call outgrow, because there was certainly a cohort of children that developed this airway obstruction, and the airway obstruction went away. Now that sounds good, but you then need to look at how did those children turn out down the track, and the answer is not good. So what that research showed is untreated obstructive airways disease, whether it resolves or not, has consequences. And what they looked at was, how much time does the child need to have airway obstruction before these consequences become evident? And the answer was 6 months. And then they looked at the age groups. Was sort of like, well, when this first starts, how does this stratify into long-term outcomes in terms of chances of having a problem? And the kids with the worst outcomes were the kids where it started under the age of 18 months. The second worst group were the kids where it started under the age of 4. And that ties in with what you just said about the age of 5 and brain development. So what we know now from that research, and then it's backed up by some Canadian research and some American research, is that there's 2 critical factors that determine how things are going to play out: the time that it starts and the duration that it goes for. And the earlier it starts, the worse, and the longer it goes for, the worse. So the outgrowing of an airway problem does not change the fact that there are long-term outcomes because there was a problem at the time. It's no different to breaking your arm. The reason that we go to such meticulous detail to get the broken arm lined up straight so that as it heals, it lines up in the best place possible, is because if we don't, it'll go through a process of healing otherwise. And we can take an X-ray and say, oh, look, the fracture's healed, but it could have healed crooked. And that then leads to deformity and functional problems later on. So we need to be very careful about what we consider outgrowing a problem, and resolution of airway obstruction does not correlate with outgrowing a problem if these children have learning and behavior problems later on, which they're certainly increased risk of. And Karen's research showed it was somewhere between 40 to 100% increased risk down the track of having behavior problems, learning problems, etc., because there was a period of development interrupted with breathing problems affecting sleep quality.
Yes, and I mean, it's such a brilliant paper because of the numbers of kids in the study, but there's lots of other papers as well that don't show great outcomes. I'm thinking of one from Duke University that actually looked long term at the likelihood of graduating from high school or secondary school, and it was pretty low with kids with sleep disorder breathing. And so yeah, I mean, early intervention just seems like common sense, right? It just
Yeah,
seems like total
yeah,
common sense when you understand all the pieces of the puzzle, because it is a bit like a puzzle, trying to understand what is going on. And in the same sense, there really is a need for multidisciplinary team members to be weighing in on what is going on with a particular child and family, to help them achieve fully functional breathing in the day and at night. And so we mentioned a bit about the dental orthodontic intervention. We briefly talked about myofunctional therapy. Can you tell us about when you would recommend it in your practice?
yeah. So, well, myofunctional therapy is the rehabilitation. So I think that's important. Is that it's part of the getting better process, and if there's underlying issues or problems, they need to be addressed first if the rehabilitation is going to be effective. So it's again, just using that analogy of if you break your leg and you're going to be rehabilitation, well, the rehabilitation is going to follow on from having the fracture and everything sorted and resolved first. And then you start laying some foundations that you can build upon, of course, but you're going to get the most of it is going to flow on from when things are optimized. So you sort of line your ducks up in a row in the right order, you'll get better outcomes. I talk to parents and say, look, we're trying to get your kid to walk up a hill, but they've got a 20-kilo backpack on. Now, we can make them force and struggle through and be miserable and terrible and never ever want to do it again. Regardless of the beautiful view that they get from the top, or we can set them up for success, get rid of the backpack, then work on the climbing the mountain. It'll be a lot easier, more productive, and there'll be less resistance to them, participating in it, and far better outcomes and so forth. So, I think you are swimming against the tide if you're trying to get a child that's got nasal obstruction where it's physically blocked to breathe through it until it's unblocked. I mean, it's again that common sense approach is, if you've got a physical obstruction that's leading to mouth breathing, and mouth breathing is just an observation. It's not a diagnosis. It's not an entity in its own right. It's just part of a clinical picture and pattern. So you look at the underlying causes and address those first, and then you can move forwards there. So what I find also is it depends on the kid and the parent. If the child is not going to cooperate, then you're not going to get anywhere. You choose your battles in life, and we can strive for perfection, but we have to meet reality at the door as well. So, in my general sense of pathway of things, it really depends on how they present. Some kids, they've just got the big tonsils, the big adenoids, and we know that to a reasonable degree, there's a good chance that if we do that, some of those kids will go through life and they'll be good as gold. But what I tell the parents is if 3 months down the track, they're not good as gold, they're going to need some help. And that help is going to be then... just 2 seconds. Sorry about that. You can edit that out.
We lose you there for a second.
Yeah,
We lost you
something weird. Sure what that was. Just bear with me. I think someone might be trying to call me. Anyway, they can wait. All right, back to you. Sorry about that.
Yeah, no problem. No,
Yeah.
so with my functional therapy, or it's a rehabilitate, it comes in many different forms. Agree, totally. And I think that when there are highly enlarged tonsils and adenoids and nasal congestion, it's really, really hard to do. Breathing re-education. My functional therapy is also about re-educating swallowing and chewing and speaking and all of those other functions that happen in the other in the airway. And I'd say that in the dental orthodontic sphere, where a myofunctional therapist is working with a dentist, there's a really important role for a myofunctional therapist to be working during, before, and after any kind of dental interventions.
Yep.
Because we don't have time to go into this today, but it plays an important role in stimulating craniofacial growth. So things like chewing, which lay down bone and help the system to grow, are really important in those preschool years. It's another huge topic. We don't need to go there today. But anyway, do you think, here's $1 million question. Do you think every child in every health clinic should be screened for breathing and sleep health?
Absolutely. What's the downside? There's no downside, and there's no great skill, effort, knowledge base required. You don't need any fancy equipment. You just need to take a minute or two just to ask them very basic questions. Does your child snore? Does your child mouth breathe? Does your child wake up tired in the morning? Those 3 questions will catch an enormous amount of the problems that we're trying to find and subsequently fix. And that can then prompt a far greater assessment, and that screening is again scientifically proven to be quite reliable in picking up a huge number of kids that can have their problems sorted well before time, and well before other diagnoses then otherwise start getting thrown around, like the ADHD and so forth, for example, where the kid's just tired and can't concentrate and focus properly.
So true. And, I started sleep and breathing screening in my clinic over 10 years ago. And I can't tell you how many siblings have been caught caught
Yeah.
just through those conversations that we open up with parents, and their awareness increases and they start watching all the kids. So super duper important. Is there anything else that you feel is an important message to share with other health professionals caring for preschool children?
So, the important thing is if you don't ask, you don't find. If you don't find, you can't fix. And the other important thing is we need to really change this perspective of wait and see and outgrow. That's scientifically not validated anymore. And we need to be mindful how these kids can present in a multitude of ways to a multitude of people. So, it can be the dentist that is finding this child, and that's to be celebrated, not condemned. It could be the speech pathologist, it could be the occupational therapist, it could be the chiropractor. No, sorry, I said dentist, but anyone in the dental team, not specifically just a dentist, but the hygienists and the therapists, speech language pathologists, the school teacher, the kindy teacher. As I say, I don't care who finds these kids.
Physios, occupational therapists,
Yep, yep. Anyone,
teaching, yeah.
anyone and everyone has an opportunity to be, basically one of our sentries at the gate, and just ask those questions. We have the school screening where they check their hearing and their vision here and there. Well, we should throw sleep into the mix. Is your kid snoring, mouth breathing, tired? Oh, okay, all right. Well, we need to look at that part of it. We've got to be mindful. We're talking about in the range of somewhere in the order of 20% of children. This is an enormous problem if 1 in 5 children have this, and of those, out of 100 kids, there's 20 of them. If we're only finding 2 or 3 of them, there's a lot of kids that we're missing. So we really need to up our game to be aware of the problem, to find the problem, and then resolve the problem.
So many pearls of wisdom, Dr. McIntosh.
You're always very kind, Sharon.
Thank you so much for sharing that. Let's pause there. Thank you so much for your words of wisdom, Dr. McIntosh. To summarise for listeners, every child's sleep and breathing health needs to be on the parent and the professional radar. In fact, everyone who has kids in their care, solving issues requires a thoughtful, curious approach to identify the cause and subsequent treatment needed, and it will involve a team. So finding the cause of sleep breathing challenges is sometimes very simple, other times not. And it may not always be easy to find the professional expertise that you need, but be persistent, because sleep is a foundation pillar of health. Don't give up. ENT specialist skills may be needed. You have been listening to Dr. David Mc Intosh share his words of wisdom so that every child can breathe well, get the sleep they need every single night to be healthy and happy. Thanks for tuning in.